Hello, I'd like to introduce you to our next speaker, Samantha O'Neill. Sam has held a number of positions in her 12-year tenure at the Lynn Community Health Center, located in Massachusetts in the United States, and she's currently the Director of Operations. Of note, she previously held a management engineer role in Business Transformation Office and is no stranger to process, system thinking, and improvement strategies. Sam will share with us today a story of how they built a flexible system in the face of COVID and how they shaped both demand and rethought their capacity. Sam?
Thank you, and thank you for having me here. So I'd like to bring all of you along to see how we've been working on creating a flexible system through shaping demand and rethinking capacity here at Lynn Community Health Center. So I'll first start with a little background on COVID's impact on us. So the United States was being hit the hardest. In Massachusetts, where the health center is located, we were the third worst affected state, right behind New York and New Jersey. And then if we continue to zoom in and go another level down within Massachusetts, our city, the city of Lynn, was the third worst affected city within the state. So we were hit pretty hard. And looking back, this was no surprise, as we know now that COVID has had a disproportionate impact on communities of color. And Lynn Community Health Center is a federally qualified health center. We serve a diverse community, and our mission is to provide high quality care to all patients, regardless of their ability to pay. So essentially, we don't turn anyone away, and we will serve anyone who comes to us seeking care. And this is our CEO, Dr. Kiame Mahaniah. So when COVID hit, as our leader, he really set the clear direction for us up front and aligned us all around the problem to solve. And that direction during COVID was that our job as a health center was to protect the hospital. We had one major hospital in the area, so with limited resources like that, we didn't want the emergency department to become overwhelmed with the patients that our health center couldn't see. So we needed to make sure that we stayed open, and so that we could work together with the hospitals to balance taking care of our community. And having this direction set clearly up front really helped us row together as best we could during the crisis. And we employed a number of strategies to do so and protect the hospitals. But one critical strategy that I want to highlight is that we had to figure out how to ensure that we were seeing the patients who needed it most so that we could prevent them from ending up in the hospital. And at the same time, like all of healthcare, we saw our services changing. So our in-person elective visits really plummeted. And in 3 weeks' time, we had our telemedicine visits up and running. And again, keeping that goal in mind of protecting the hospital, with our services changing this way, how we decided to use our telemedicine capacity and our in-person capacity was critical. At the time, with such limited in-person access, it was making really hard choices about who should get which type of care and when. So whether that healthy young adult versus somebody with medical conditions should have that in-person visit. And a lot of organizations around us were having to turn people away, lay staff off, or even shutting down. And because we knew that we had this vital role to play in our community to protect the hospitals from clogging up, we were determined not to shut down. And we were still there for our community throughout this time. And ultimately, this entire thing just made a huge impact on our access and scheduling. So to zoom out a bit and view that impact through this time period, I'll start by showing you pre-COVID what our access looked like. So we had urgent care and primary care. So all of our urgent care and same-day needs for our patients would be taken care of by our urgent care team. And then our primary care team saw patients for more routine and follow-up care that was scheduled in advance. And this was scheduled through a first in, first out basis on a monthly cadence. And then COVID hit, and we found ourselves working under new COVID restrictions. And as we saw on the previous slides, treatment was postponed. Those in-person visits really dropped, and we tried to serve patients through televisits as much as possible. And then, like every other healthcare facility, we were working with so much unknown as we tried to rapidly develop new service lines in this COVID world, such as testing. And then as we approached our phase reopening towards where we are now, we had this mixture of pent-up demand and new demand seeking treatment. However, our on-site services were still pretty limited, and we continued to face staffing challenges as we tried to balance our resources between our different service lines. So the problem for us was that, one, if you look at the scales across the bottom, you could see that even pre-COVID, we were never fully able to meet our patient demand, even pre-COVID, but COVID really made this problem worse. And through that growing and evolving demand, you could see our scale really changed. And now we were unable to meet our patients, now more than ever. And then secondly, this mixed demand made it really difficult to figure out how do we design our capacity to meet our patients' needs, what was going to be the right access to approach the extreme demand that we were facing. So next, I'll tell you what we started to do at our health center about this. And we began by looking at our access by measuring the demand coming into our urgent care department by hour of day and day of week, so that we could better understand it. So here at the 10 a.m. hour that's outlined there, we had about 20 patients arriving at the 10 o'clock hour. And based on our patient per hour rate, that would require that we staff 9 doctors to meet this demand during that hour. And then right after that, at the 11 o'clock hour, that demand drops to about 8 patients, which would only require 3.5 doctors to meet that demand. So the demand fluctuated quite a bit. And our first question was naturally, can we just match our staffing to serve this demand? And this was not really an option for us because, for one, we didn't have 9 providers available at once within our urgent care team. But most of all, the fluctuation called for really choppy schedules, which also wasn't an option within our staffing. So we then looked at our structure. So these 2 circles up on the top right, we have urgent care and primary care, 2 separate departments serving 2 different demands. So we thought, do we need to step back and really rethink what our definition of capacity is? Are we thinking too narrowly with our current design by saying that these doctors will care for urgent care services and these doctors will only care for primary care services? If we could somehow rethink our capacity and maybe overlap these teams to adjust our resources, would that allow us to design our capacity to better match the changing demand by hour that we were seeing? And so we felt that we had an opportunity to explore here. And so we did. And we took a closer look at the data and found that, in fact, 84% of our patients seen in urgent care actually had a primary care doctor at Lynn Community Health Center. And some of these patients truly did have an urgent need, so it was definitely appropriate for them to be seen in our urgent care team. However, some were just seen there because they weren't able to get in to see their doctor when they wanted to be seen. So by rethinking our capacity with this overlap, we were able to set aside a reserved portion within our primary care capacity, so that green area, to match the demand for patients wanting to get in today or tomorrow. And this reserved capacity was used to either compensate for hours of the day where there was too much demand for urgent care to handle alone, or to take care of primary care patients who wanted a same-day visit. And most importantly, this created the flexibility that we needed during COVID to adjust our capacity on a weekly basis to the needs of our patients as it fluctuated, as well as the unpredictable nature of the pandemic. So we decided to test this out on one of our primary care teams called Green Team. And with this experiment, each week we would study the current demand for urgent care services to determine the amount of doctors' capacity needed for that upcoming week. And that grid below that we have there shows the current demand for the week and then the total number of doctors that we needed at different hours of the day to meet the demand. And since we had this newly reserved capacity, again, that green area overlap that we just created, we matched the demand at heavier hours of the day. So like that 10 a.m. hour that we saw that required 9 doctors, we would match our doctor staffing to ensure we had that. And then any remaining reserved capacity that we didn't necessarily need at other hours of the day, we would convert to primary care visits and then release it for scheduling. And what we saw from this experiment was that we could match the number of providers needed as it changed throughout the day. and there was no increase in wait time for urgent care services, even as the volume changed. And then patients coming into urgent care who had a primary care doctor could be served directly on their primary care team, which was a plus for our patients because it could help with the continuity of care. So we felt that we were pretty pleased with this experiment and felt that now that we've kind of played around with our capacity design a bit, we began thinking about the other end of the scale. Is there any way that we could perhaps shape our patient demand for services to help with this imbalance as well? So looking at us pre-COVID, we could argue that we were shaping demand, but to protect ourselves. We opened schedules on a monthly basis, and once our schedules were full, we would essentially say, sorry, our schedules are full. Please call again next month when our schedule is open. And because we couldn't give all of our patients an appointment, if a patient said that they needed to be seen sooner or insisted that they be seen sooner, we would end up advising that patient just to go to urgent care. So at times we were even misusing our own urgent care to an extent. And because we opened that scheduling door once a month, we created these peaks and valleys in our patient demand. So pretty much we were the victim of our own doing in many ways. And after we learned what we did through COVID, we decided that instead we wanted to figure out how do we change our system to really address what our patients actually want and need versus what we felt we needed to do to protect ourselves. And a couple of things that we did were we built on our improvement from that green team experiment to create soon day access. So there was that reserved capacity being released for scheduling on a weekly basis, dependent on the demand that week. So our thought was, could we layer on this and build on thoughtful soon day access so that patients are able to get in the near future versus only being able to get in on the same day and only in advance. And then we also created hold lists for patients who needed a follow-up at a later point. So rather than putting it on the patient to call back at a specific month or date, we would use hold lists to put the patient in queue for the time that they're due. And these hold lists were sorted by priority level so that we could understand the level of urgency as well as due date and visit type and doctor. And so with all of these elements, we could really visualize our demand and drill up and down in many ways. So by offering these options, instead of our prior system where on the left, where we were advising our patients to call once a month and protecting ourselves, we began to create a system where we could shape our demand differently and offer our patients the ability to call anytime. And depending on what their request or need is, then we could meet it accordingly. So for example, if a patient needs an appointment within a week or needs to be seen today, then we have a pathway for that. And then if a patient wants to be seen in the future, if we can't provide an appointment slot right then and there to that patient, then we have a pathway for that as well through hold lists rather than telling them that, sorry, you'll have to try again. So these improvements within our capacity and demand definitely helped us get better, but we're still not doing as great as we'd like. And we continue to learn and build on our improvements as we go. And one area that we've been developing is determining what different learning needs to be happening within the different roles so that we can make this learning constructive and help us continue building a flexible system. So as an operations leader, I'm hoping to learn, are we ahead or behind? And if we're behind, how behind are we? If we're accumulating a backlog, where might we be accumulating a backlog? What's our highest demand that we're seeing? Is there potentially more demand for one particular service versus another, such as more demand for physical exams? And then does that demand look the same for each doctor? Or does the demand look different if we drill down to the individual level because each provider carries a different patient panel? And then ultimately trying to study if our capacity as we designed it really matches what our patients are asking for. Are we providing the services that they're actually seeking? And that learning looks different for our local leaders. So one of our local leaders, her name is Angela. She leads our outreach team that works on these hold lists. She's looking to learn on a daily basis, are we ahead or behind? Are we red or green for today? And she's been working on ways to really measure and see if the team is red or green. And depending on the status for the day, she's able to adjust her team's priorities or troubleshoot as needed. And being able to monitor the data as closely as this has helped Angela to determine how much help her team may need, areas for training opportunities, and so forth. And then some days we're in the green, which is nice, and some days we're in the red. So what happens when we're red? So this area we continue to really explore together, as there's been a lot of rich learning that we've gained from this. And so far, there have been several reasons that we've fallen behind or have noticed that we're in the red. But a couple examples here is that in one instance, a doctor had a backlog accumulating higher in comparison to the other doctors. So Angela was able to really dig into the details to understand why. And she realized that it was due to that doctor having time off, which interrupted the team's ability to schedule because they were consistently scheduling off of the hold list. So having no connection between the doctor's time off and the hold list entries can really have an impact on the access. And then another instance was backlog accumulating due to appointment mismatch. So we saw that the appointment date that were intended on the hold list isn't actually a cadence that we've even designed for within our doctor's schedules. So that was also a very valuable discovery and helped us understand what our patients truly need. And ultimately, because we're able to actually see that we're red, our local leaders can actually catch it earlier on, and we can approach it together to gain an understanding and problem solve. And the system that we're building is still very much a work in progress. So it has been incredibly valuable to learn each time that we're in the red, because it tells us where we might have gaps, where we need to potentially adjust our design or dedicate more resources in learning too. And we have had some wins that we've been able to celebrate. So one was that we were able to demonstrate with that initial green team experiment that almost all of the patients were being seen by their primary care doctor, which also helped us to gain buy-in from other doctors on this as well. In green team, we had a baseline of 32% of patients seeing their primary care doctor, and we were able to reach 97%. And then organization-wide, we're continuing with directional improvement from a baseline of 40% to 91% currently. And then productivity in urgent care and our 3 other primary care teams where we spread this to has increased by 7.3% as we were able to take care of more patients. And then third, because we began capturing demand on these hold lists, we were able to measure and see not just what's red, but also what's green, such as that we scheduled 93% of our patients with high priority status by the time that they were due. So these patients were successfully scheduled on time for the services that they needed, which was really impressive for us. And I can say that we are really proud of our teams for these improvements and for all the work that they've put in. And we continue to work our way through this journey and building on it piece by piece. And along the way, we're focusing on developing our local leaders, figuring out how do we as an organization are supporting problem solving at the appropriate level, and then continuing to study our patient demand as it changes so that we're able to improve and truly match our systems to what our patients want and need. And one major piece that that we've been learning is that the continuous part of continuous improvement means that we really have to have flexible systems in order to improve. Our local leaders and our teams really need the right levers to work with and flexibility to adjust. And I'd also like to say that while COVID made our access worse for sure, it really pushed us to pivot quickly and create flexibility in a way that we hadn't before. And so we really hope to continue shaping our demand where we can, and then designing our capacity to better match our patient demand. And so thank you for listening, and thank you for letting me share our journey with you.
Thank you, Sam. That was really terrific. I had a front row seat watching this work, so I appreciate that. So let us kick us off. So if anyone has any questions, please enter it in the Q&A section on the right part of your screen. If you shrink your the slide part of your screen, you'll see Q&A, please. All right. But let me ask you this, Sam. So you just showed, I think it was the slide was around the wins that you've had. And I think what's really interesting is that I think two of the three measures that you showed are patient-centric, if you will, that you're actually measuring wins by how patients would measure wins. And you talked about patient-first thinking earlier, right? Percent of patients seeing their primary care doctor as opposed to someone else, or percentage of high priority patients being scheduled on time. So those two measures are really thinking about the patients, and many organizations will have measures about the organization, bottom line results, often tied to revenue. Was that a shift for Lynn Community Health Center, or how did those measures come to be?
I want to say that I feel that it was a natural shift because a lot of the teams, especially, knew that patients really wanted to see their doctor. They developed that one-on-one relationship, and they knew that the patients really wanted to get back in to see their provider. That's their team, that's their home. And so a percentage of patients seeing their primary care doctor was definitely a natural one. And I think focusing on that, it brings the other benefits along with it too, because having that relationship with the provider and being able to provide that continuity of care means that they're showing up to their appointments. There's less of a no-show rate for that provider. So those things come afterwards. But I think it was very natural. It was just following listening to our patients and following what they wanted.
Great. So a win-win, really, for everybody. Okay. So you talked a lot about the technical changes you made, right? And showed data and how you analyzed your current state to understand how do we schedule or staff versus how the appointments were lined up as an example. And I wondered, this is a huge change, right? Getting people to change is not easy. So I wonder if you could talk about the social side of these big changes. You did a great job sharing the technical. How did that go, especially as you're talking about changing schedules or even overlapping capacity from urgent care and primary care?
Yes, it was a huge change, I think. And I think we spent some time kind of communicating to the different groups. And I think there were different benefits to different roles. Like, for example, one of the key benefits that we shared with our providers was that for their buy-in was increasing that continuity of care, that percentage of seeing their own patients. But I think in general, across all of the roles, everyone felt the same about no one wanted to turn patients away anymore. And the other piece was that we all knew that our demand was just severely outweighing our capacity, and especially through COVID. And so knowing these two things, we really tried to present these changes as not a new system, but as building blocks that we could kind of put in place to allow us to start improving on this together. And that it wasn't in its final state. It was, like I said, the building blocks, and keeping that central, because we all want to feel like we're taking care of our patients. We all want to feel like if we have something to provide our patients. So by keeping that central and showing how these changes could be useful and supportive to each role in being able to fulfill that, it helped us move forward.
Okay. So we have a question from Armor. Thank you. What is the main difficulty in building flexible healthcare systems in the post-COVID stage?
I think definitely ties into the question that you just asked me, Alice, the social piece. So really getting everyone on the same page, especially when it's a system like this where there's so many layers to it and a lot of different cadences or different ways that we schedule. I would say like organization and training for all of that has been really challenging. And then I would say too, just trying to make sure that we're staying on top of what our patients need, because we're tracking the demand coming into the hold list. We're also seeing the demand coming into our urgent care as walk-ins. So you're really like monitoring all of the different areas and trying to stay on top of the data that you're seeing.
Yeah, and I love that you talked about the local teams monitoring if they're ahead or behind, right? The simple question of are we ahead or behind, red or green? It's one or the other, and building that habit. Was that a challenge to do, or did people like doing that and understood why that was important? How did that go?
I think it was definitely a challenge at first, because I think it's always uncomfortable to think or to even say that you or your team are like in the red. Um, but I think that it's been really incredible seeing the team develop, and understand that red isn't necessarily a reflection of the team's performance or a reflection of them and their work. It's actually a tool that could help show what barriers might be getting in the way of their work. And so it actually supports them in being able to do their work successfully. So I think it was tough at first, but we were able to work through each time that we were read together and actually show that it's not you, it's what's in the system and what do we need to do and how can we look at that and understand where we need to maybe adjust or better support you in your role.
I congratulate you on cultivating that learning mindset and driving to root cause, right? Asking why. So I think that's terrific. Last question. What's next on this topic for you and your team?
I think we have a lot. But I think one thing I can say that's next is that we're actually working on now is that we've noticed a higher pent up demand for physical exams specifically. So what we're working on right now is an alternative way to be able to address that need, because we know that we still don't have that capacity available within our schedules to meet all of the demand for physical exams, but figuring out maybe a different way that we could help our patients with this need, maybe through our televisits, since we have capacity there. So ultimately, just continuing on that path, using the information from our hold list to drive the design of our templates, and even at the individual level at some point where we can actually use that information to determine if a provider should be considered open panel or closed panel because maybe their demand is telling us something different. Maybe it's telling us that it's a lot more complex and it requires X number of follow-ups, which takes up this much capacity. So I think getting more into that and developing our access cadence is what's on our roadmap next.
Excellent. Thank you very much for sharing your story. We appreciate it.
Thank you.